So very good evening to all of you. So this is a new series of IAPS online activity, which is IAPS Vishwa-Mitra, and we will try to involve our NRI friends and learn from their experience. Today we have with us Dr. Gera from Perth Children's Hospital, Australia. And to moderate this session on pediatric thoracoscopy, a safe approach, we have with us Dr. Kirti Rathod, additional professor at IAPS Jodhpur. So I hand over the mic to Dr. Kirti Rathod for further proceedings.
Good evening, all. First of all, I'm very humbled to get this opportunity to start the Vishwa-Mitra as a moderator, and thank you very much for this. And most of us know Dr. Gera. He's done his MCH from Mumbai, and then immediately he was he passed and then he moved to Australia, if I'm right. So that's like he had planned it before, I guess.
It was 1 year. It was 1 year I worked as post 7 and then went.
So yeah, 1 year you worked in Mumbai, and then you were in you went to Australia.
Yeah.
He is a fellow of Royal Australian College of Surgeons, and he's got his master's in hospital management and research. And now he is the associate professor in Perth University, and he's the lead of trauma, thoracoscopy, and oncology at this center. So and he's written multiple textbook chapters and a lot of publications. So it's a privilege to have you, sir. And I'm again privileged to moderate this talk. So I'll hand over it to you. And
thank you, Kirti.
And
it's a privilege for me as well. When vacation, Dr. Ramesh Babu mentioned that they are starting this, and I said, I'll be very happy to do one of the talks, but I was not, sure that I'll be doing the first one. But no, thank you very much for giving this opportunity. It was a great journey as a surgeon and as a minimal invasive surgeon. And as a safe approach, I mentioned because the approach started when I came to Bombay in 2000, and we were introduced to minimal invasive surgery by Dr. Rasik and Dr. Sanjay Oak and Dr. Sandesh Parelkar. Now I live in Western Australia. I did my training in Sydney and moved to Perth in 2012, so have been there since then. And as you can see the map, we are well far away from eastern states, around 4 hours in a different time zone. More closer to Singapore and Malaysia rather than Sydney and Melbourne. So these are the various indications of thoracoscopic procedures, and almost all of them are quite standard these days. And have been done in various centers, and we do in our center as well. And I'll go through a few of them which I have done, and what kind of experience and issues can have, and we can share those. But why for first thoracoscopy and why not thoracotomy? So we know that when we do a big cut on the chest, there can be issues with the shoulder movement. There can be remnant scoliosis, and as you become a bit older, you see your long-term patients. And recently, some patients who had diaphragmatic hernia with a big cut on the abdomen, they do get quite a significant scoliosis. In the TOF, even if you do open, I have seen TOFs who had muscle cutting incision, they do have scoliosis, but in last 15 or 20 years or so, I have been doing TOFs only with muscle sparing. So that is less of issue. But again, memory maldevelopment, atrophy of chest wall muscle, all these issues comes from a big thoracotomy incision. So it's not ideal. Apart from that, a lot of pain issues. So most of my patients will go home at day 3 after getting lobectomy, or any chest surgery, their chest tube will be out in day second and they'll be home by day third. But if you've done a thoracotomy, then they'll be stuck to bed for a long time. So most important thing in thoracoscopy, which I have realized over the year, is position and ergonomics. First, how I make my life easy is I try to visualize a lesion inside the chest while the patient is on table, that how the lung is going to be, how I'm going to approach. So imagine if the lesion is very close to spine, like a posterior lesion, I'll be standing on the opposite side of the patient, almost a semi-prone, so that I can have a triangularization of my instrument and lead the lesion and lead to the lesion. I will draw a picture of a tumor, if I'm doing a tumor, onto the chest wall where exactly the lesion is, so that I know exactly where my port placement is going to be. Anterior lesions, if there's an apical lesion, I'll stand on the same side on the back of the patient, but most of my thoracoscopic surgeries, I'll be standing on the front of the patient rather than the back of the patient. And before I start, I'll see where my monitors are and everything else and what instruments I require. This was first up experience from Nair Hospital when we started minimal invasive surgery with my mentors out there. So we published our 15-20 cases of initial empyema, which was very simple. We used to do thoracotomies for empyema at that time, and I remember all that ooze and blood. And then we started doing cases with VATS. We selected cases very carefully, that we are not doing like complex organizing peel cases, and we're doing very, very early on cases where it's easy to expand the lung. Then we put camera in some hydrated cyst. I still remember there were 3 cases. All 3 cases had, we aspirated those hydrated cysts, but we were not that confident at that time to do lobectomies. So we did a mini thoracotomy and did a lobectomy. I remember showing this paper to Justin Kelly when I was working with him in Perth. He was locuming, and you can see he saw this was a good paper. So I just kept it as a memento at that time. And people will remember Justin Kelly, I think most of you. We even tried putting camera in a thoracic trauma. I remember this patient from Nair. He came from interior UP. He fell from a cartwheel and had a pneumothorax. And he was admitted somewhere in a peripheral hospital in Thane. He came to us with a bubbling chest tube with the pneumothorax in spite of having chest tube, had a CT, and it was suspected that he has a bronchopleural fistula. We put a camera in there, and I remember we could see endotracheal tube. It was a major bronchus leak. We did a mini thoracotomy and closed it, because that time we thought that we were not that technically sound. It was start of our journey in thoracoscopy, and the safe approach was not to push the boundaries, but take the help of that technology to diagnose these cases and maybe manage them in a safe way. Then I came to Sydney, and that time, even in Sydney, the minimal invasive surgery, this was 2005, 2006. I was working in Westmed. They were doing just thoracoscopy for empyema that time, and we were not even doing lap appendices a lot, but it was just coming up a lot, a role of thoracoscopy. And then we got referred these chest wall tumors that time, and we were thinking like, how we excise them. We used to do a muscle sparing thoracotomy and remove the rib lesion, and you won't know how much will be the extent of the tumor. And I was working with Eric Lahai at that time. So we came up with this idea that we will put a thoracoscope to assess the chest wall tumor. And from inside, while we visualize the tumor, we'll put a methylene blue outside the ribs, that how much we want to resect. And then we resected under thoracoscopic vision. That time, again, we were not doing thoracoscopic lobectomies. All the lobectomies were getting done open, because We didn't have instrumentation. Ligashore was not in picture at that time. The sealing devices are not there. So that was very safe. We did around 10 cases that got published that time, and became quite a standard approach to do these tumors under vision, and that if they have a rib lesion and you are not sure how much you have to extend, you can do take help of this technology. And as I was talking about empyema, when we put first port, we use a telescope to create a working space. I'm quite careful. I usually don't do my empyema surgeries. If they're very early on, that's fine. But we usually get referred patients from a respiratory team after they have tried everything else. And I do ask for a CT because in my mind, if they have a lung abscess or bronchopleural fistula, then I will try to manage them medically rather than me intervening, because I will probably create more fistulas if it is already an organizing peel, or will be more careful in those cases if they have not medically responded to the treatment. So while you are doing surgery, first few you can't see very well in empyema. You take help of your blunt instruments and suction to just find where the fissure is, and then work along with the lung. When I started practice in Perth, because we were doing empyema quite a bit in Sydney, we did collaborate with ICU, because most of these patients end up in ICU, but they do have very good results with the the streptokinase and plasminogen activators. So are at first treatment modality is those regions, and then if they don't respond, then only we come for surgery. Recently, we looked at our even experience of lung abscesses in our hospital from 15 years. There are only a couple of cases where I had to go in and do lobectomies for those. Otherwise, most of the lung abscesses were managed non-operatively. If empyema is going to go to theater, I think communication is very important, and communication not only with the patient, communication with the ICU and anesthetist. I had a patient, I was doing a empyema surgery. Recently, in the middle of the surgery, patient had almost a pre-arrest that I had to stop the surgery, and they had to do a CPR. And what they realized that a bit of a plug of pus had spilled over to the other leg, because their cuff was not blocking the tube very well. So they had to suck the tube. So you have to work with your anesthetist a lot, because when you put the patient in a position as well, the secretions tend to go on the other side, and whole physiology will change. So anesthetist and intensivist are very important part of team at that time. So you have to collaborate with them so that you have a safe approach for that patient. Again, whenever we do any major lobectomies or lung surgery, I always do a single lung ventilation. If it's an older child, they'll put a double lumen ATT, but if it is a smaller child, they'll put a bronchial blocker. And I have not done a lobectomy or a major lung surgery without a single lung ventilation. Again, ergonomics, I think it is very important that the surgeon does the position of the patient and looking at the lesion and seeing where the port placement is. Because if the port placement is not right, your case is not going to get right. And secondly is the table, and I kept my table quite low when I'm doing those cases, because I don't want my shoulders to be high and they get tired. Probably there won't be an issue when the robotic surgery come. So one of the simplest procedure when you learn thoracoscopic surgery is lung biopsy. So if you have a good respiratory or pediatric team and they refer you some cases and you want to learn this, you can just, when we started and we didn't have staplers, we used to just put an endo loop on the lung and we didn't have any issues, but now we do have staplers. And I think this one is a just right stapler in a newborn for lung biopsy where they were suspecting an interstitial lung disease. I've done lung biopsies even like in very, very young kids. Sequestration is another very, very simple surgery where you see an aberrant blood vessel coming from the lung, and you just need to take this with the hemoclip or a big stapler. But recently, again, there is a paper from Boston children whether do you really need to remove these because the risk of infection is quite low. But till now, we have been removing all patients. Spontaneous pneumothorax, we see quite a bit of patients here. Common in Marfan syndrome, present in teenage children, and there'll be usually blebs on the top. And usually we don't do this as a first when they have primary pneumothorax, but if they have two episodes of pneumothorax, we do that, and then remove the pleura from the apex from first to almost fifth rib so that the lung can get stuck there. Out of whatever cases I've done in 10 years, there was only one case where we had to use a talc fluorodesis, but most of the other patients were just good results and did not have any recurrent pneumothorax after doing apical blackbectomy. CDH we don't usually do for the newborns when they are not hemodynamically stable or they are on nitric or other inotropes. But if they have a child who's really stable, and this particular child, I think it presented around 6 months of age, had a very isolated small defect with the stomach in the chest. And you can see the stomach just went back with insufflation of a gas. And it was nice, a few sutures, and child did well. Again, it was critical for us to manage that, just identify those patients where it will be safe. When I was training in Sydney, we did few diaphragmatic hernia with the laparoscopic approach, and few of them came out with a decisive bowel obstruction because there was too much handling of the bowel. So I have not done that in my consultant years, that procedure again. I've done few tumors which are isolated. Most of them will be ganglioneuromas or biopsies with neuroblastoma. And again, we do a MRI angio or a CT angio to look at their blood supply, that where exactly the tumor is. And it will, in my experience, they will always say that the vessels are very close to the tumor. It is encasing the tumor, but the definite thing is going to be when you remove the tumor. And as you see that this particular lesion was sitting right on the aorta, but it was very easy to dissect. The last tumor I've done only a few weeks ago, where an anesthetist took around 1.5 hours to put all the tubes, but it was that easy that it came out exactly in 25 minutes. But again, there was a case which was early on in my consultant years, which was ganglioneuroma, which came back as a neuroblastoma after 5 years of initial resection. And this time the tumor was very stuck to aorta and pulmonary hilum. And while I was resecting it, I ended up nicking the pulmonary vein with the ligature. So we had to do an urgent thoracotomy within seconds to kind of close that hole in the pulmonary vein because child was losing blood very fast. So that's another thing which is, and I think in that particular case, probably the tip, I was not visualizing the tip of the ligature very well, and that's why that nick had happened. And that is the only one case where I had to convert so far when I had planned a thoracoscopy in a particular case. Thoracoscopic lobectomy, we do it for intralobar sequestrations or CPAMs. We do have some cases of cystic fibrosis with bronchiectasis, although with new antibiotics, that is getting less and less. But for lobar emphysema, usually they are newborn. They are not commonly to get thoracoscopic lobectomy, but that's another indication. Again, the CT scan and the planning is really important for thoracoscopic lobectomies because first for port placement, secondly, are you doing, is it a peripheral lesion? Will you just do a segmentectomy or you will remove the whole lobe? And in our center, we do these at around 2 years of age or when the child is more than 10 kilo, because we do want them to put a pulmonary broncher. I know Steve Robbins, Rothenberg does them in newborn time, even at age of 6 months, but we have not ventured into that yet. So this particular case again highlights the importance of, this was looking like a single kind of a cyst. And if we look at this video, this looked like this single cyst in a case which you don't have the background history. You might say that I'll just do a segmentectomy, but this particular child had a kidney tumor as well. And once we did the genetic studies, it was shown that he has got Dicer mutation, which might be an indication that child might have a pleuropulmonary blastoma. So I did, along with this cyst, we did a lobectomy, and the report did claim that it was a pleuropulmonary blastoma. It was not a CPAM. So again, that is another point that in all the CPAMs, a lot of centers do a conservative management. There will be some cases where you won't be able to diagnose whether all the big cysts should get dissemination or not. That is another question, and we don't have a guideline along with that yet. Now, these are my friends. Without them, I don't go for thoracoscopic surgery. These are the 3 staplers I will use, and you can see these are medium thickness and quite a thick one and a thin stapler, and they come in 30 millimeter and 45 millimeter. And if you're going to lung, then you might use a 60 millimeter. So usually for the vessels, we'll use this orange and pink one. And for the big tissue or bronchus, you will use a thick stapler. These all stapler go on a 12 millimeter instrument. So if we have, that is another limiting thing, because the caliber of the port need to be wide. So for the just right stapler, you have 5 millimeter, but we had issue with the just right in older children, that with big vessels, we noticed a little bit of ooze when we put that just right 5 millimeter stapler. So we stick with these 3 stapler, but I do use quite a bit of Hemolox on the blood vessels if they are not too big. And I use LigaSure for all my lobectomies. So technique-wise, I start with the fissure dissection, staying on the side of lobe which is coming out, and then take vessel by vessel. And I do it the same way I used to do open lobectomies, and then go on the pulmonary vein and keep the bronchus till the end. So it will be fissure, dissection, segmental vessels, pulmonary vein, and the bronchus in the end, and the lobe will come out. But as a routine, we have a setup thoracotomy tray and a trolley that we don't need to go for instruments. So this is set up, ready to go in case we have to convert. And as I said, I had one case where I had to convert, and that is very scary when you have a significant bleed in a thoracoscopy setup, but you should be ready for eventualities. Every thoracoscopic lobectomy, I'll have a cross-match blood in the fridge in theater in case there is significant bleed. So that is one protocol that we should follow to deliver safe surgery. Recently, we have done a few thymomectomies for patients with myasthenia gravis when they were not responding to the treatment, which is steroids or immunoglobulins. As you can see, that the dissection is quite difficult. You need to safeguard the phrenic nerve. You go around brachiocephalic and root, and you see that is just the dissection is combination of blunt and dissection, and you can see the thymus coming, and it is bit different texture or color than the normal orange fat, and the patient is kind of in this is a supine position with one side elevated, so that we approach from both sides to remove both the thymus. Now we've done only few cases of this. We just but it's an excellent result when you remove thymus. Their myasthenia gravis improves significantly. So this is again, you have to but approach with very safety, because the thymus wraps around all the blood vessels there. This was an interesting case again. A child who was sitting in the classroom, somehow his pencil was, somebody put a pencil on the back of the desk, and as he sit, it went through his chest. And he came in the emergency department with the pencil going through his chest and a pneumothorax. So we just introduced a thoracoscope, keeping the pencil stable that it shouldn't push in. And luckily he didn't had any significant injuries. We had a similar case like that recently with a knife as well. So all these cases can be certainly done, but as long as you know you have got your thoracotomy ready. So I know a lot of centers are doing TOF repair. Personally, I have done few Fockers, stage 1 for long atresia, but I have personally not done this surgery myself. But how to get started, probably get a bigger size child and see how much you can go comfortably, and then be ready to convert again and try again. I've assisted few cases, but I've not myself done TOF yet. This is again a backbone of our center, where you need to understand how this work. I put all my lobectomies on -10 negative suction, and this operator should work well in terms of negative suction, and it should not be faulty when you're doing any type of surgery. So I will not say that there is any bar or any age. Just look at your patient and say the patient is stable. Patient selection is very important. There are distinct advantages. There is no question that if a thoracoscopy can be done, then thoracotomy should not be even considered. And results speak of themselves. Thank you very much. Happy to discuss.
Thank you very much, sir.
You.
It was really interesting, and the way you defined your journey from Mumbai to Australia, it's fantastic. So it's a good journey, and there are a few questions in the chat. Rasik sir has few questions actually. Sir, you want to ask yourself, sir, please, Rasik sir?
I mean, do you see, after putting an ICD, you said that you take out the ICD on day 1 or day 2 and discharge the following day. So does it depend on how much it is?
So that, Rasik sir, that I will decide on only 2 factors. One is that there is no continuous air leak and the lung is expanded. Sorry. Sorry, there is some note.
Yeah.
So one is that the lung is expanded, and the second, of course, is that the drainage is less than 20 mils in 24 hours.
Okay.
And for the lobectomies, it is very, very unusual that they'll get more drainage. Unless you have some ongoing issues there. Otherwise, we'll take it. We'll do one X-ray post-op, and then next X-ray next morning. And if that X-ray is normal, then we'll clamp it second day and take it out after 6 hours.
Yeah. So in diaphragmatic hernia, somehow we have seen the drainage to continue little longer than otherwise,
Yeah.
So, yeah, I agree. Then lobectomy does not drain a lot, and you can take it out in day 2, day 3.
Usually, sir, for CDHs, we don't put chest drains.
Okay, okay.
So we leave the CDHs without drain because the lung is going to be hypoplastic.
Yeah.
And there is going to be cavity there which will fill up eventually with fluid. So we do not put any chest drains in diaphragmatic hernia as a routine.
Okay. Even in open, you did not put IC.
No, we don't put any drains in diaphragmatic hernia.
Okay.
So Purushottam, I have seen here they do that bulb suction, that small one come in diaphragmatic hernia.
Yeah. No.
Like they use sometime without suction, they just had that suction created by the bulb.
No, we have not done. We do, like, if say a child has got a significant collection at day 10 or something and it is causing mediastinal shift, we might consider a pigtail catheter then, but it is quite rare for our diaphragmatic hernia to get that as well.
Yeah. Only one more comment. You showed that low pressure suction device, some company A or something.
Atrium, yeah.
Yeah. So in India, there is a Medela suction device like that available. And I don't know whether many people probably don't know in India where you can elaborate on that. You may be using routinely.
Yeah.
We have used in few patients, but it's a very nice device. Just tell everybody about that.
Can you show that again?
On to the slide.
Yeah, I'll just go back to that.
Yeah.
Again, 1 second. So this is if everybody can see that. So this is the atrium suction. So we put a fluid here, just up to -5 to take that intrapleural pressure. And this is one side, but the other side has got a dial where you can set up the pressure, how much you want to set up. So you want to set -10 or -20 or -15 negative pressure. Usually I keep around -20 centimeter after a lobectomy. And then you don't need to control the suction on the wall or suction on the apparatus. So you can put that suction directly on this the chest tube, that dial, because that is going to be controlled anyway. So it is just sucking at -20, not at the full wall suction. So we don't control that at the wall or at the suction machine. We control at that chest tube, chest bottle device.
Yeah, and the beauty of this is it will give you amount of air which is leaked in 24 hours or on ongoing basis. It will tell you exact amount of fluid which is drained. And for those, the cost wise, I think this cost may be about 1.5 lakh. The entire device and the bottle will cost you every time. If you want to use new one, maybe a few thousand rupees, just for the information of the audience.
Yeah.
Yeah.
No, it's quite a standard, this atrium, and if people need more information, I do have a PDF for this, how to take care. I can share it with with people.
It's a good discussion going on. I just wanted to know, like, am I audible? Sorry.
Yeah, you're audible.
Yeah.
Yes. How you decide, depending on the surgery? You said lobectomy, you said some pressures, but there are a lot of other thoracoscopic surgeries we do.
Yeah.
And not many people are actually fan of negative suction. The pediatricians are not. The pediatric intensivists also are not. We push them to do it in my setup actually. They don't agree to do that. Actually, we have to tell them to do it. So it's like sometimes with empymas and lobectomy. Lobectomies might not need it actually, to be honest. CDH might need it. So how we decide according to the weight of the patient what pressures to put, because it's always confusing what the suction pressure to put in different scenarios and different age groups and weight groups.
I think like what we there is no rules that I have seen, but in a newborn child we always keep it under 10 or like in between 5 to 10. But for empymas we if there is, so again -10 or -20 depends on air leak and how much lung expansion is in empyema. So if you don't have adequate lung expansion and you have a significant air leak, I will use -20. And in some cases of empyema, I don't know whether you guys have used or not, there is something, Heimlich valve. Have you used Heimlich valve before?
Yes, a lot of times we have to use it.
Yeah.
Chronic
So,
empymas, we have to use it.
yeah, so before you transition to the Heimlich valve, you want to get rid of all the fluid and everything. I use it -20, and then if you've got lung expanded, reasonably expansion of lung with ongoing leakage, then you go to Heimlich valve. But for newborns, we keep it under 10. We never go more than that. But for CDH, I don't have any experience because I don't put chest drains in CDH.
We also don't put, I personally don't put, but sometimes the neonatologist will push you to put post-operatively because they are worried about that thing.
But they
And
mostly, they are not on, we don't put on them on negative suction.
yeah.
We had one patient, like recently we had a patient who had a post-op chylothorax, and he was getting significant blockage of the tube. We had to put negative suction for some days,
So
but usually
chylothorax
we avoid
because
it.
of what? Sorry again. Which
Chylothorax we had, a
CDH,
significant
yes.
chylothorax post-CDH.
Okay.
And that's another thing with the lobectomy and CDHs is a chylothorax. So that is a significant complication, and we need to identify very early on. So if you have a significant leakage of any contents, and sometimes the children are nil oral, so you won't get that milky content. So send that for chylomicrons or triglycerides. And if you identify early on, then you can start even medium chain triglyceride, and that settles quite well actually.
Okay.
So Purushottam, I have a quick
and
question.
Doctor, sorry.
Sorry, Tarun.
Yeah, so for like for the fistulas, when you have a persistent fistula for more than like maybe 3 or 5 days or 7 days, you guys have any experience with the blood patch?
Yeah. So we did have quite a number of patients, maybe around 10. So what we did was we don't act.
Can you explain everyone for blood patch? I think I don't know if we're using in India or not. I don't know.
Yeah, what, sorry, blood? Yeah. No, we have not used blood.
Patch.
No. If that was a question,
No, blood
I have
patch.
not used blood patch. No, I have not used blood patch. I thought you were just talking about fistula.
So what they're talking in some, I think I don't have a literature in front of me right now, but what they have done, if you have a more than 5 to 7 days leakage, fistula there, you take the patient's own blood and inject through the chest tube and clamp it for 1 hour. And they have seen it works. It closed the fistula. So I think we should try that. Whenever I think I thought I will do it, and it closed the next day. So I never got the chance to use it. So I don't know. Dr. Rasik knows Dr. Trey Eubank.
Yeah.
So I talked to him a few times because they may have a more volume than I have in my center. So this is I think concept I like it. Blood patch they use in when they do epidural in OBGYN side. When they have a persistent leakage from the CSF leak, they use blood patch. That is mostly used there, but I think they have been tried in bronchopleural fistula too.
Usually all the fistulas from us close eventually, but it does take some time. It has taken 2-3 weeks even to close it. but we're not
Yeah, I
sure.
think that is the time after 7 days, they said you should try it to maybe shorten the hospital stay and all
Yeah.
that.
I have
Okay,
a few
thank you.
questions. Kirti, if you allow me, I have a few questions.
Yes, please.
No, I was.
Okay.
You raised hand before, so yeah, please.
Okay, fine. So there are a few like beginners questions, like two questions related to hydrated cyst. Normally, like a small baby, you're not able to put 10 port, and these hydrated cysts usually doesn't come out easily with a 5 suction, even if you have a very strong suction. So how do you deal with it? Second thing, second question about hydrated is like which leak or which sort of communication you will do a capitonage while which are those whom you are going to leave, I mean not do the capitonage, and how do you avoid post-operative surgical emphysema after hydrated surgery in lung hydrated. These were the two questions related to hydrated, and one question related to empyema. It's a very, I mean, beginner's question. How do you decide the port placement for various types of various locations of empyema?
So look, the empyema is, as I said, first thing is that if there is a cavity or a bronchopleural fistula or something like where the lung is more adherent, I always do a CT for that. So while you're doing a CT, you will know where the most diseased lung is. So I will stay away from that. And I will go, if there is a liquid component of empyema someplace, I will put my first port there, so that I can suck some fluid and then have a bit of visualization, and then put a camera and then place my second ports. Is that answer that empyema question?
And the location of the pleural thickness, I mean pleural peel is also important, like which
Yeah, of
part you
course,
want to
pleural peel is
excise.
important.
So if some
Yeah.
area is
No,
like
definitely.
thickened, then that should be the area of the focus while putting the ports.
Yeah.
Yeah.
And with the hydrated look, we didn't have many hydrateds here in Australia. So if you have a small cyst, they are easy to control with thoracoscopic. But otherwise, if you have a large cyst, we have ended up doing a thoracotomy. But you guys might have more cases
Yeah.
than us for hydrated
So,
to
like the point which I wanted to highlight is like large cyst, usually we come across large cyst only.
Yeah.
And it is very difficult to remove with 5 suction cannula. So
Yeah.
what I do is like that Yakult suction cannula, that plastic cannula, I put directly without the port. And that is a very good way to suck out the cyst. If 10 port insertion is not possible. If
Yeah.
10 port is possible, then I usually prefer a 10 port and a 10 suction, which usually like 100% of the times it sucks the cyst well. Now
Yeah.
about the leak, like a very minor leak, I usually don't close. But if it's a major leak, like something 3-4 millimeter above, then I repair it. Otherwise, I don't repair it.
Do you use any like we have a couple of products known as Tissil, which is and we have one product known as glue barn, which are artificial glues which we put on lung.
Okay.
So if we have any significant leak, which we can't, by even doing lobectomy or for hydrated or any other reason, and there was significant leak, it's quite difficult to suture lung that way.
Yeah.
So we just put Tissil or glue barn, and that managed it very well. I had a patient which was a newborn. He had a very complex CPAM, which almost covered 90% of his chest, and it was that big that we couldn't remove that whole lobe. We had to just do a kind of segmentectomy, and he developed a bronchopleural fistula and oversaw whatever I could and put a glue barn or Tissil. It is known as it's a tissue glue. I'm sure,
Fibrin
and
glue
that
or
works
something?
very well with the lungs.
It's fibrin glue or cyanoacrylate?
It is cyanoacrylate glue barn.
Okay.
Yeah.
We can give a try to this.
Yeah. No, that works very well.
Over to you, Kirti.
Can I make a comment on
Yes, sir,
hydrated?
please.
Yes, sir, please.
Sir,
I don't know how many of you have seen Dr. Palanivelu's modification of the trocar. So that's a large trocar, 10-12 millimeter. which is one port for insufflation and one side hub for insufflation, one for suction, and through one you can see. So if you use that, it's like a directly you can put within the hydrated cyst and suck out the everything. And it's a beautiful way of doing it. Of course, you can see even biliary communication as well as pulmonary or bronchial communication also. And I mean, if it is large or whatever, then you may have to do further suturing or whatever. For that, you may not be able to do through the single trocar, but otherwise you can do it. We had done few cases like that, and then you just put the drain through the same port and come out. So it becomes like a minimally invasive, completely with one trocar you can do everything. It's a nice way of doing it. It may work in some patient, it may not work in some. Yeah.
It has to be on the surface also, like cyst has to be on the surface.
Right.
Yes. So I was exactly about to say the same. Actually, there's a cyst in the port technique. But if you don't have that exact port, we have modified the technique. So what we do is like you take a 12 mm port. This is for older children. Put the 12 mm port inside the cyst. You use a camera and one working port. So there's a camera, one working port, and a 12 mm port exactly in the cyst. And everything goes under vision from the cyst, and you can do everything whatever you want for the liver, for the lung. You can do all the you can even put the momentum and all with one hand. So you don't need two, you need only one working port, you need one camera port, and there's a port in the cyst. And that, as sir said, we can put drain through that only. So that
There
is
is
one thing.
Yeah, there is one more concern related to like big size stapler putting through intercostal space in small babies. Is there any
Yes.
chance of like long duration you're keeping it there, injuring the intercostal nerve or something like that, or it is just
We
theoretical?
don't get hydrated cyst in younger children.
No, I'm
First
not
of all,
talking about hydrated. I am just talking about like stapler, use of
Look,
stapler in thoracoscopy.
oh yes,
I-
so you get 5 mm. Yeah, okay.
we have used staplers, as I said, that all our kids for the stapler are mostly 2 years. I've used even staplers for lung biopsy for young kids, didn't have any issue
Okay.
with any nerve injury or any long-term effects. So we've been doing this for last 20 years, the lobectomy is now here. So
Agree.
none, I will say 0% of any intercostal.
So it's
with
just a
the 10
theoretical,
mil
I mean.
port. It's a 10 mil port, and just the only thing which is sometime is a technical challenging is that if you're using a 45 millimeter stapler, you just need to place the place where you want to staple it in a way that you can open the stapler widely, but never had any issue with the nerve injury.
And the other option is like a harmonic, they have a ligashware. And there's the 5 millimeter stapler too, but again.
Yeah, that's what I was, Tarun, I was talking, the Just Right stapler, we have that one.
5 millimeter.
But the issue we have with 5 millimeter was because we are doing children at 2 years. Sometimes the big vessels, they just still ooze after 5 millimeters. So we were not confident doing big vessels, which are very chunky with that 5 millimeter.
If it is oozing, can you use endoloop after that?
Look, it's really tedious because you don't have that much stump once you have run the stapler. The vessels are, you don't, you can put a hemolock on that and it becomes a little tricky. So we have used it. We still use Just Right on small vessels, but if it is a significant vessel like a pulmonary vein or something or bronchus, we stay with the those 8 millimeter. Like Ethicon has got a little angled stapler which is right easy to engage, and the diameter is 7.5. That can go through 10 millimeter port as well. So yeah.
Okay, thank you.
Yeah, so there's a question from the in a group that they say that are there any late post-op complications in patients where TISL was used to seal small leaks.
No, no. There's no post-op complications with the TC.
With the use of T-cell, right? Okay.
No, there was no post-op complication with TC.
So I have one question that I assume in Australia there are limited cases of thoracic.
Yeah,
compared
like
to
in our unit we do maybe 8 or 10 lobectomies a year and
Yes.
10 or 12 TOFs a year.
Yes.
So that's why we keep our the workflow in between two surgeons in the unit.
Yes.
That or the registrars, like we don't we don't do one
my
a
question
year.
is different. My question is
Yeah.
different because we are newly established center in India. Now we are like 12 years old, when we started. So what I wanted to ask is that because our workload is not that high, how you convince your residents, in the sense, because you have to train them, right?
Yeah.
If you do thoracoscopy, then the chances of them doing open is decreased,
Yeah.
is limited, and they still have
Yeah.
to fill their logbooks. So
Yeah.
how we do that?
So look up. It's a logbook is important for there are steps of logbook. Okay, there are simple cases, there are complex cases. What I do with my trainees is let them do the part of even advanced procedure. So if I'm doing a lobectomy, the trainee will put the port and start a bit of case and let him do a little bit till I take over. So it counts both productive that they have done the case as well, and it has counted towards their case as well. But they have not. It's not important that they have not completed the whole case, but they got the the sense of out of it, and they'll get confidence to move further next time.
I think their question was that what about the open thoracotomy?
So
I got correct.
yeah. So look, it's the same thing. So 20 years ago, when I came to Perth, I met this trainee. I was a fellow who had done only 3 open appendicectomies and 50 lap appendicectomies. And ask the trainees, general surgery trainees of this generation to do an open collie, they will not be able to do it. They will want some help to do open collie, but they will do lap collie closed eyes. I don't think for training we can offer a patient something which is not standard. So I can't do an open lobectomy just for the sake that I'm going to train somebody to do it. I don't think that is fair. But there are still open thoracotomies like TOFs in our unit. Still, we do significant number of TOFs which are all open. So they do get hang of open thoracotomies. Every once in a while, you will have a CLE, a lobar emphysema in a newborn, which we do open. So they will do those kind of thoracotomies. But I think for CPAM and all.
Same we are facing here for pyloromyotomy too.
Yeah, I would like to bring back this discussion on thoracoscopy because we will try to cover this topic some of the time. So, like in diaphragmatic hernia, I would like to know from you as well as other experts here, what type of diaphragmatic hernia you would not like to do a thoracoscopic repair which has high chances of recurrence, like a wider defect. You also mentioned in your talk that lateral defect or something very close to the chest wall where there is no lateral edge. How do you deal such situations, and how often you use mesh for that or some patch for that? Question to you as well.
I'm very selective in my. There might be more experts in the area, but I'm very selective in my CDHs. I will do thoracoscopy only for those cases where there was no requirement of nitric. They came with the conventional ventilation or no ventilation, or they were like 6 months old, or they had an incidental diagnosis of CDHs. All cases where there was significant pulmonary hypertension, or they required nitric at some stage, or high flow, I will probably stay, and we do abdominal approach in those cases. So whatever CDHs I've done thoracoscopically without patch. If they required a patch, that will be an open repair for me. But I'm happy to hear other people's experience around this.
Can I say something on this?
Yeah, please.
Yes.
You are the moderator.
So, thank you for making me the moderator, to be honest. So I'm very young in this group, no, unexperienced a lot as well. So I will do all CDS thoracoscopically if the anesthetist is happy. Thoracoscopic, whatever kind it is. I'll put patch also thoracoscopically.
What
I
patch you use?
And what
I
are the
use
results,
simple.
Kirti?
If I get a good, I use prolinos. मतलब जो
Prolene mesh also.
whatever we get actually, to be
Vicro
honest.
mesh is also good. Like I use a combination of Vicryl and Prolene mesh. That is
Yes,
also
but that
good.
expensive. So whatever is in supply, I'll use it. It's because in a government setup, whatever is available, I'll use it.
Rasik sir would like to comment on this question,
So
like the
I'll
difficult
finish
CDS.
I'll
Please,
finish
please.
my thing. Sorry,
No,
Rasik sir will be advancing what I'm trying to say
yeah,
actually.
correct.
So the
Sorry.
thing is that I'll repair as much I can. I'll repair everything. I'll even put sutures with the chest wall and the ribs thoracoscopically with the defect and close it completely. But if the defect is too large and I've repaired it, I will I'll put like a second layer of patch on it, and I'll use tackers. So luckily we have absorbable tackers now, PDS tackers in the hospital. I don't know how long they will stay, but we have absorbable tackers. So I put tackers on the repair and
I
touch.
agree. That's a quite nice way to put the patch on. I use it for my open when I do open.
Yeah,
Get it together and put a patch on the top.
yeah. So do all suturing and put a patch on the top, and then it is works super well actually. Almost all my cases. I don't know when they come for follow up, but so far it has worked well because it's just 12 years. So it's good.
Something which has not recurred for 3-4 years won't recur. Don't worry.
Yeah.
And we have those other tackers also, the metallic tackers which adults use for hernias. Those are also okay, but you always have a fear of putting them in the spleen and all, and like you have to be very careful when you use those tackers.
So again, just one question on that I will ask. So are those children on nitric or HFO when you're doing them?
I have done only open. I have not done any CDH on HFO in India. I'll be very honest.
The
Do
most
we
of
have
our
done?
kids are
Do we have
operated
a
on
HFO here?
in the NICU these
We
days.
do have HF,
Okay.
but we will somehow work hard and bring them back on conventional and do them later. So that's how we work in in AIMS Jodhpur.
Yeah.
I have operated around 3-4 CDH on HFO when I was in UK, and I have operated a couple of them on ECMO as well.
Yeah.
My
That's
short
what-
experience in UK.
Yeah, that's
So
what the routine.
that's a different story actually. We can't discuss because it's a different scenario at all. मतलब वो तो माहौल ही अलग है, मतलब वो different होता है. So that's different.
No, that's
Yeah.
I think another thing is for these cases, like if you have just to say that the CDHs and all, we have NICU. Sometimes it's difficult to wean them off from HFO and you're waiting to get conventional. If you have a good NICU setup, you can do those cases in the NICU because I do all my CDHs in NICU these days. We don't transfer them to theater.
Yes,
And then the child is in that same environment. It's not getting transferred to theater.
Yes, that is doable. Same with gastrocrisis. You can do it there, you know.
Yeah, we do all laparotomies under 1 kilo in NICU with neck perforations and gastroschisis and this. Even I've done a couple of TOFs around 800 grams, like very premature TOFs. We just went and ligated them like 600 grams.
That's fantastic. You have to convince your neonatology team, and I have done it at least 3-4 times here in India. It's difficult to convince them that मैं पूरा operation NICU में करने वाला है, but that's possible.
It's doable as long as the anesthetist and NICU team and you are happy. So.
Yeah, but it's possible. It's doable actually.
Well done.
So Rasik sir, would you like to give expert comment?
If we are going to put mesh from chest side, like what Kirti said, regular Prolene or Prolene Vicryl combination are fine. If you are going to put from abdominal side, like in open surgery, then it is better to have coated mesh whichever company you want. Now, personally, we have used couple of times mesh in last 2-3 years only. Prior to that, we never needed it. In last 2 years, I have put on thoracoscopic side also mesh. But as Kirti said, the suturing is very cumbersome. We do not have takers, but we have suture it. And now, I mean, I have just done in couple of cases, so you can't and you know, you have not planned, you can't do it well. But if I get a new case uh, of putting a mesh, in the sense you have put the sutures from medial to lateral side. The lateral side is usually difficult. You may have gap of 1 centimeter, 2 centimeter, you are worried, and you want to put a mesh there. So what you can do is you can plan the how you are going to put the mesh, and accordingly you can even at the end of mesh put the sutures, and then you go in and just take the bite from thoracic side on the diaphragm or on the chest wall. So it becomes easier. So the mesh will go with the suture and needle, which are non-absorbable sutures. So then it becomes easier. Otherwise, it's very cumbersome to put the sutures in that area. Of course, I mean, we may end up doing some tricks like what we do, subcutaneous sutures. Something similar you can do even when you put the mesh, though there will be some risk of getting it infected, which may not be good. So my personal experience of putting a mesh is not a lot. We have used, of course, this again in a relatively older child, means may not be in a newborn period, but little older child where we have put the mesh. Now, couple of other things like operating in NICU is a possibility which we did it in US. We have never done, at least in India as of now. There was a question for one patient who was on a high frequency oscillatory ventilation, where probably we would have done biopsy, but patient did not agree, and I don't know what ultimately happened to that patient. Personally, I will not like to operate in NICU for multiple reasons. One is my back will hurt. I'm always worried about that. And the second, the lights are not good. The instruments are, you are compromising. So personally, I don't like to operate, and nobody has forced me so far. So I am happy with that. So yeah, but yes, it can be done. We had done diaphragmatic hernia on ECMO in USA, but we have ECMO, we have HFO, everything, but so far not operated in NICU. Our, of course, workload of newborn surgery is not very high, being a completely corporate hospital. Yeah. So yes, mesh can be used. Regular Prolene mesh on thoracic side, and from abdominal side, coated mesh.
Sir, do you have Gore-Tex mesh? Thank you, Rasik sir. You have
Yeah.
Gore-Tex patch in India?
We have very robust pediatric cardiac department, and they will give us whenever we need it.
That's what we
Yes.
usually use. We used to use Surgisys, but now we have changed to Gore-Tex in all our cases of diaphragmatic hernia.
So we have our friends in pediatric cardiac surgery. They will have the sheet, and you can just cut whatever amount of.
Gore-Tex is it works quite nicely in CDH. We usually, I used to use Surgisys, but now they have taken it off shelf. And about the NICU again, in new hospital, we sort of requested government to make a small procedure room with the ceiling light, which solved that purpose of a light. So if you are into designing a new hospital, just try to convince them to put a minor procedure room in the NICU with the light so that you can do minor procedures there.
I think we have crossed already the time. Kirti, what is your suggestion? Should we continue the discussion or
Yeah,
go to the conclusion?
we can conclude, but I just, because only 4 of us are talking, I would like to ask, there are like around 53 people now in the group. If they can open up their mics and say something about it, whether it was useful and what are their, if they liked it
I
or if they want further knowledge, it would be grateful.
Dr. Vikesh and Dr. Rathod, I think it's a good initiative from the blessing of seniors. I think we should continue it. And if we have a more audience from IAPS India, I think would be better. But I think this is the first
Yeah, we will work
one,
hard.
and
Yeah, we'll.
because the government centers like Sion, where I was, and other big center in Mumbai itself, and then other part of the country, they have like a lot of volume. I think we can learn a lot from them too on the same time.
Correct. But I have one invited, speaker to give the concluding remark, Professor Dr. Ramesh Babu, our IAPS president. May I request Dr. Ramesh Babu to please open up his mic and say a few words, what is the idea behind IAPS Vishwa-Mitra? Are you around or are you asleep, Dr. Ramesh Babu?
It's just
please.
9, I think it should be.
No, he giggles. He just now giggled. No, he's not there.
It's too soon to sleep in India.
I think he
sleeps
left.
very early. He
He
sleeps
left.
very early.
He was there, but he left.
Yeah, okay.
Anyone
Okay,
else wants
okay.
to say anything, like, because our first thing and we decided on a short notice, maybe we have less people and everyone busy with a long weekend, everyone has a plan. Plus there's thoracic meeting already going on in Pondicherry. So a lot of things happening at the
And
same
what I
time.
see is like such videos, they get like high viewership. Once I upload on the channel, then viewership like goes beyond 400 or 500, something like that. So it's a matter of like feasibility to attend the seminar.
There were around 67, 68 logged in one time. I think
Yeah.
around 20 have left. So
gradually that increases. Now we have upgraded our Zoom to 500. So at times, like in our previous next gen mock examination, attendance used to be like 140, 130, something like that. It will pick up. But thank you very much, both of you, opening batsman and opening bowler, both of you. And thank you all the members for sparing your valuable time. Thank you, Rasik sir, for sparing
Sorry,
your
Dr. Vikesh, Dr. Kamal Kant has raised his hand just before.
Yeah,
can I just thank IAPS first for giving me this opportunity to interact with you guys, because I really enjoyed it, and take this opportunity to thank Dr. Rasik, who showed us the way.
Right.
And it was well back, and that you saw that first slide, so that's where the journey started. So thank you again.
Kamal, please.
Good evening, sir. Thank you. Thanks a lot. And greetings from Himachal Pradesh, Shimla. It was very nice talk and I enjoyed it a lot. And thanks for this initiative from my side, sir. Thank you. Thanks a lot. Good discussion on Monday, today. And
Monday is in limelight these days.
Ji, sir. It was nice to know, because NICU may doing putting drains, ICD and all, we have been doing that. But taking it to next level, definitely India needs some time, but definitely we can do it. Thank you for making this possible, sir. Thank you.
Thank you. So now we'll conclude the session. Thank you very much. Have a very good night.